Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, episode 9 of the Athlete's First Performance Podcast. And today, James and I are going to be talking about acute lateral ankle sprains. Just to give you a little bit of breakdown of the organization of this episode, we're going to start by defining what an acute lateral ankle sprain is. Then we're going to get into what we're looking for when we first see someone in the clinic after an ankle sprain. And then we'll move into management strategies and then eventually return to sport. This whole podcast is going to be based off the ankle stability and movement coordination impairments, lateral ankle ligament sprains clinical practice guideline from JOSPT, which was first put out in 2013 and then revised in 2021. So let's get right into it, James. You want to start off by defining what an ankle sprain is?
Yeah, so a lateral ankle sprain is most common in court or indoor sport athletes like volleyball or basketball. And it's usually as a result of a plantar flexion and inversion mechanism. So if someone lands from a jump and rolls onto the lateral part of their ankle, or if an athlete steps on another opponent's foot and they roll their ankle to the outside, those are the common mechanisms. And it's usually an injury to the anterior talofibular ligament, so ATFL. And it is a very common and prevalent injury in these athletes. And oftentimes the problem is that people think it's pretty benign. So a lot of times people just think, oh, it's just an ankle sprain. I'll be back to sport, or I'll be back to normal within a couple of days. But the problem with that thinking is they get back to their sport and they still have some lingering deficits like strain through range of motion. So I think it's a super important topic for us as PTs who are trying to get more into that direct access role, to be able to be confident and capable with dealing with athletes or general pop that have these acute ankle sprains.
Yeah, I think one of the things I read was that because, obviously there's some injuries that get a little bit more limelight, I guess, in the media with athletes. Like ACL is one of them, particularly concussions now for positive reasons, and ankle sprains another one. But I think it's because it's almost so prominent. People will say, oh, I just rolled an ankle, I'll walk it off and I'll be back whenever the pain's gone. And that can either lead to them not seeing anybody for care off that. And if they're just waiting for that one deficit, being pain, to go away, and swelling probably too, they may be missing a lot of the underlying conditions that could come off of it, like you said, decreased strength or proprioception issues and things like that, which then can possibly cause a recurrence. And then you'd move into the chronic ankle instability category. So as far as acute versus chronic, what is considered an acute ankle sprain?
So anytime that we define acute in terms of ankle sprains, we're looking at within 1 to 2 weeks of that initial onset or that initial injury. So that's important because in these clinical guidelines, they define the lateral ankle sprain different from that chronic ankle instability. So the whole goal of treating these lateral ankle sprains acutely is to help prevent them from having that chronic instability. And we know that there's going to be a different type of treatment with the acute versus the chronic. So the whole goal is to get confident with that acute care to limit that chronicity.
Yeah, and then if you look at, if we move into, just before we get into examination, the risk factors for an acute lateral ankle sprain, the clinical practice guideline broke it up into non-modifiable and modifiable intrinsic risk factors, and then into extrinsic risk factors. So we look at non-modifiable; those are obviously risk factors that can't be changed. And the primary two things that they had listed was previous injury and gender, with previous injury being obviously a previous lateral ankle sprain. There was conflicting evidence on whether a previous ankle sprain elevates the risk for another one. Just in my mind, that would make sense that it would. And then the other was females tended to have a higher rate of ankle sprains than males. What are your thoughts, James, on the previous injury? It said conflicting evidence to a degree, but what do you think? Do you feel like that plays a role?
Yeah, I think for most things, a previous history of injury to a knee or an ankle or shoulder is going to lead to a higher increased risk for future injury. And that can be partly to blame on us, incomplete rehab or not good enough rehab, or it just can be anatomical. So you already injured an area and it's not getting back to its full capacity, and then it's at increased risk.
Yeah, I think that I would agree, because particularly when we get farther along in this podcast, we'll talk about prevention strategies, and there has been some evidence that exercise can prevent a recurrent ankle sprain. So to me, if we're working on trying to prevent a recurrent ankle sprain through exercise, that would lead me to think that a previous ankle sprain would probably elevate the risk for another one, particularly if you're not doing appropriate rehab, like you said, or just not seeking the care. As far as the modifiable intrinsic risk factors, there's some range of motion deficits, particularly with dorsiflexion. There's some specific numbers in some of the studies that they gave, but primarily that dorsiflexion was measured in weight bearing. And then some strength issues, particularly in the hips, which I thought was pretty interesting. So do you want to talk, what are your thoughts on range of motion and strength as far as risk factors? Obviously, there's something that we're going to look at in the examination. But is there anything else or anything surprising to you about what they listed as the risk factors for range of motion and strength?
Yeah, I think the biggest thing that was pretty much presented throughout this whole entire CPG was the open chain ankle range of motion wasn't as predictive or as important as that closed chain. So I think everyone needs to start using that weight bearing lunge dorsiflexion assessment based off of this paper, just to be able to assess that closed kinetic chain dorsiflexion. And they said anything greater than 2.5 centimeters or 1 inch asymmetry is going to lead to increased risk of ankle sprain. So that's a super easy measurement to take. Just put a piece of tape on the wall and just mark off 1, 2, 3, 4, 5, 6 inches, and then you can just quickly compare that right versus left closed kinetic chain dorsiflexion.
What about the hip strength stuff?
Yeah. So no, I think that's super important, because we know anytime you're on a single leg, I mean, your ankle is working, but it's also a lot of your lateral hip and hip extensor muscles that are controlling that lower extremity, the pelvic control and trunk control. So if we can get good ways to measure it, like in this paper, it said hip abduction strength less than 33% body weight is an increased risk factor. So if we can get any type of handheld dynamometry or just specific objective measures for hip strength in terms of adduction and extension, that'll be important to target as a modifiable risk factor.
Yeah, I think the only way to really get that number would be a handheld dynamometer, as far as like the most practical ways. Definitely something you could probably still try, or you may be able to do like some sort of endurance type test to see if you could test it. But I kind of wonder with that too, because I know some of the research out there with knee pain says that lateral hips, typically the lateral hip will be weak, and they don't know if it's the chicken or the egg. So I can't remember if these are prospective studies that told us that, but it's interesting to say that both the knee and the hip and the ankle, if there's problems, the hip should be targeted. And it's, like you said, a lot of these things are single leg injuries, so the hip is definitely working for that.
Yeah. And I've read some things, just like when you have a knee injury, your quad muscle is inhibited. I've read some things like after you get an ankle injury, your glute muscles are inhibited. So
yeah. And I don't know why. I mean, does anyone know?
Yeah, I don't know
why that happens.
Once they're in the clinic, I guess it doesn't really matter. You need to work on it, so just work on it.
True. Okay. Yeah, I mean, that makes sense. It's something that you find a deficit and you work on it. It's nice to know maybe why, but the treatment's going to be the same. So, and then some other things that they looked at was functional performance. So things like this Y balance test, hop test, and things like that. What do you use? I mean, do you use any of these when you're first seeing somebody? Is this something that you're concerned about in the beginning of treatment?
Yeah, it depends where they're at. So if they're super acute and painful and swollen, and they're not able to put a whole bunch of weight on their with their leg or their ankle without a whole bunch of pain, I'm probably not going to be doing hop testing. But if they're moderate, they're walking and their pain is not too bad, I'll test the Y balance test just to see where they're at, just to get a starting score and then objectively track that. But yeah, it just depends on where they're at with the hop testing. So if it's someone that's coming in 2 weeks after an injury and they're doing okay, but they're not confident with getting back to sport, I'll just want to see how they hop on 2 legs and then hop on 1 leg in place. Just start with that and then you can go from there.
Yeah,
What do
no,
you think?
I think yeah, it's perfect. I don't. It all depends on what their starting point is, and I think with anything, at least for me, I just want to find their baseline and go from there. So yeah, if someone comes in and I'll check to see if they can even move it comfortably, if they can weight bear on it. You can see that when they walk in. If they can weight bear, then we'll see if they can balance, and if they can do that comfortably, then yeah, you can move into a Y balance. Hop test, I probably would. I don't know. I feel like if someone's hopping on a single leg when they first come into PT, I feel like you don't see that very often. So I don't think that's something that I would do. I don't think it's something that I would see or be able to do. Yeah. So I don't know about the hop test stuff, but it makes sense. Obviously, that's something that you'd want to work towards, maybe measured later on as an indicator for progression. There was just a stat on here that in regards to adolescent athletes, that they took greater than 15, a little over 15 seconds to complete a single leg hop test, with 10 hops over 30, or 10 hops over a 30 centimeter distance. Is that right?
Mm-hmm.
Yeah. Is that meaning that each hop is 30 centimeters?
Yeah.
10
So
reps over 30 centimeters seems small.
yeah, that's pretty vague. So a lot of times with that 30-meter distance, it might be going
Side
over and
side or
back.
forward.
Yeah, forward, backward, over and back. A lot of times I'll see that with a lateral. So like lateral side to side hop over 30 centimeter distance.
Gotcha. Yeah, that makes more sense. And then if they took that long, it even, they're at higher risk of another ankle sprain in the next 10 months or so. Okay, so we talked about the court sport athletes typically being at a higher risk because that'd be considered an extrinsic risk factor. The only way to change that is to change sports or stop participating, and that's not typically on the board. So that one will probably stay the same. They're also more likely to occur in the second half of games, so maybe fatigue plays a role in a lateral ankle sprain. And then it was noted that, and this is a big thing now, particularly in the NFL, and this is for soccer players, but there's no difference between artificial turf and grass. Just a little bit of a thing happening with my football team, the Carolina Panthers. They just switched from grass to turf because they are going to have a Major League Soccer team in the same stadium. And there's been quite a bit of, I guess, people weren't too happy with it just because of the possibility of increased injuries, but it looks like, at least with ankle sprains, there's no major difference. Is there any other extrinsic risk factors you can think of, or any thoughts you have on that?
That was pretty much it in the paper. But it's always interesting. Why do you think it's more of an increased risk for court sports versus field sports? You think it's the nature of the sport, or you think it's the surface?
I would definitely say I would lean more towards the surface and the nature of the sport. But I almost feel like you could argue that either way. But I don't know. Just to me, it seems like particularly with basketball, because you're in such close quarters, and this would be an argument for the sport, particularly with jumping and things like that. If you have that mechanism where you land on someone's foot and roll it, like you said earlier, I think in my lifetime when I've rolled my ankle, it's probably been most playing basketball.
Mm-hmm.
But I also think the court it's quite tacky, like particularly in your whole goal is to have shoes that like stick to the floor. So I think that can create an issue also. But turf to me would, like with cleats, would seemingly be the same thing. What are your thoughts on that?
Yeah, the first thing that came to mind was just the nature of the sport. So like basketball and volleyball, just all the repetitive jumping that they have to do. Then especially in basketball, if you're getting a rebound and there's 4 other people around you, there's so much more risk of just landing on someone's foot versus like soccer or football, where it's more of just speed. I mean, there's jumping in those sports, but it's more of just like sprinting and cutting versus all the repetitive jumping. So that's
Yeah,
the first thing that I thought of.
Yeah, I think in regards to football, it's going to be stepping most likely on somebody that's going to make you roll it, or you're going to get rolled up on.
Yeah.
As far as like ankle sprains. Yeah, that makes sense. So they did talk about some more functional performance measures, and it's just basically what you can do or not do, and inability to complete a jumping and landing task within 2 weeks of the initial ankle sprain, poor dynamic postural control, and then just a low self-reported function were all predictors of moving into a chronic ankle instability category at the 6-month mark. So just things that you can keep an eye on. Doesn't mean they're necessarily going to be into that point, but things to note, and also things that should, particularly with the self-reported function, things that should be talked about and addressed. Interestingly, too, the other risk factors, and we'll talk about this in prevention, was not using a brace, and then not participating in an exercise program that includes balance training. So that's helpful for, I know particularly the bracing is helpful for preventing a primary ankle sprain, but also preventing a recurrent one. Are you ready to move on into the acute phase of things that you're looking for and what you may start out with treatment?
Yeah, we can do that, and we'll catch up with the prophylactic bracing later. We can talk about that because that's a pretty big discussion too. Taping versus bracing versus exercise. Yeah. Nothing. Yeah.
Okay, well, let's just go into what, like, if someone comes into your clinic, we've kind of touched on this, but we can organize this a little bit better. When someone comes in right after, well, in the acute phase of an ankle sprain, what are you going to look for? What are you going to ask? What does the examination look like?
So the first thing is just getting a history. So there's usually a specific mechanism of injury that led to the ankle sprain. And then the biggest thing that I want to see, are they walking in the clinic? Are they weight bearing on it? Because we know the Ottawa ankle rules are being able to weight bear at least 4 steps immediately after the injury and in the emergency department or walking into your clinic. So that's the biggest thing that I want to rule out any type of fracture. So we can get it right into that. So those are the 4 weight bearing steps. And then being tenured to palpation on the posterior edge or the tip of the medial and lateral malleoli within like a 6 centimeter distance up the leg. And then same thing, checking for tenderness to palpation of the navicular or the base of the 5th metatarsal. So if any of those are positive, that's going to lead to a referral for imaging. So that's the biggest thing that I want to make sure that they're at the right spot. So if those are positive, then we're sending them off to get imaging. The next thing that I want to do is just check swelling. So you can do like a figure of 8 measurement around the malleoli, because that's pretty easy to do and pretty easy to track as well to see where they're at. So checking swelling and then checking range of motion. So I'll first do it in an open chain off the table, seeing how well they can just actively move in a different dorsiflexion, plantar flexion, depending how severe irritable it is, checking inversion, eversion. But the most important ones I want to see, if it's very acute, are just that sagittal plane, dorsiflexion, plantar flexion. And then I'll check the closed kinetic chain dorsiflexion range of motion, and then go into just manual muscle testing, knee, hip, see if they can produce isometric force with the ankle, see how painful or irritable it is, and then get started with just checking joint accessory motion. So again, seeing if they're able to tolerate any type of low level manual therapy just to help decrease pain, just get that joint moving. Is there anything else that you like to look at first day?
No, I think that's pretty good. The only thing that I would throw in there, and I don't know exactly where I would put it, it just depends on the irritability, but just palpation, just to figure out, exactly where the sore areas are. I really like the manual muscle test, even if it's just light manual muscle test for the ankle, because I'll probably use that in treatment if the ankle is really irritable. If you have to start there with like an isometric, particularly eversion, I like to keep an eye on. That I think the only time you wouldn't do the ankle dorsiflexion, the weight bearing version, is if they had issues weight bearing. But if you do everything on the table first, you'll get a pretty clear idea whether you think they'll be able to tolerate that. But yeah, then you would just get, if they can weight bear, I may check balance while they're
Yeah, I was
that
going to
first
say,
day.
I forgot to say balance.
And it's definitely not wrong to check everything on the other side to get a baseline, and then when they're ready, you can do those same measures on the involved side. But yeah, that's pretty much it. I think in the beginning, my main focus is swelling and pain, and doing anything that I can to, while maintaining, kind of just like with the ACL, trying to get like a quiet knee, trying to get the ankle to calm down, but move it as much as possible. We can get back into bracing here for a second, maybe after you talk about your initial treatment. So I know you said some manual therapy that you would do. What other things would you work on that very first day?
Yeah, so going back to the practice guidelines, anything in terms of A to P dorsiflexion mobilizations are all grade A evidence. So anything to help improve that talocrural joint mobility and improve dorsiflexion, that's going to be one of my main goals early on, just to help improve pain, range of motion, and tolerance to exercise. And then just getting light muscle activation. So a lot of times if there's an acute ankle sprain, they're swelling, their toes and their foot intrinsics are all inhibited. So a lot of times I'll just check super easy. I call it toe yoga. So foot flat and just seeing if they can activate their big toe into dorsiflexion, their little four toes into dorsiflexion, and then keeping all the toes up, tapping the big toe down, tapping the little four toes down. Simple things like towel curls, marble pickups, and like just spreading the toes. So just super simple things that they can do on their own to help improve those foot intrinsics. And then just pain-free ankle active range of motion, plantar flexion, dorsiflexion, just like ankle pumps, just moving up, down, not really going to do side to side, especially if it's super acute and painful. And then start with hip open chain hip exercises. So like side lying, abduction, or clams, depending how much tolerance they have to weight bearing, like bridges, start getting a little bit of input to the ankle. And then again, depending on where they're at, starting with a balance progression. It might be like 2 feet balance progression, just side shifting or weight shifting side to side, just getting input and load onto the ankle.
Yeah, I think all those are good. Like I said, I like the isometrics for the ankle if it's really uncomfortable. When you can get into side to side comfortably, I would like to do that as soon as possible, just to work, particularly the everters and the posterior tib, just based on, and the CPG says this, but you can have a delayed reaction time of the posterior tib, which is important to kind of, when you start to proprioceptively feel that ankle inverting, you want the posterior tib or the everters to be able to correct that quickly. So as soon as that can get moving, that'd be great. The other thing that I've seen, and there is research, so right after an ankle sprain, ideally the biggest thing is early weight bearing and get it moving. But there is research for like a grade 3 sprain to show that immobilization is helpful, only really up to the 10-day mark. So immobilizing for, I think it was 4 weeks was the number they gave, but basically longer term immobilization made it, and ended up making it a longer time to return to work or sport, and also decrease the number of those who had an ankle sprain that could return to sport. So some strict immobilization is okay. And if someone comes in and they're immobilized, actually I tend to see people do pretty good once they get out of the boot. Sometimes I would see them, they've been in the boot for however long, and they come in and they're already out of it. But if they come in with the boot, that's when I'm going to start. I'm not going to go side to side, but I'll kind of put a bigger emphasis on just letting them actively move it, what they're comfortable with, and trying to do a little bit of isos. And then, yeah, obviously you can always go up the chain to work on the hip if you need to. But yeah, that's probably what I would start with. And again, if they can balance, I may have them do a little bit of balance. I'm always like a little hesitant to have them start doing heel raises like super early. But maybe like a little floating heel isometric or something like that if they're comfortable with it. But typically just keeping it simple and low level in the beginning, just to get an idea of what you're dealing with and how it's going to react, is a good start.
Yeah. And then what do you do for swelling management? Do you do like send them home with a ACE wrap or like compression stocking or socks? Do you do any of that if your
Yeah,
clinic has it?
I don't know if I don't know if the guideline talked about compression. I can't remember. I know it talked about ice, but no, I like compression for swelling. Ice wasn't really recommended. I kind of leave that up to the patient if they want to use ice. I haven't really seen anything that supported it to help reduce swelling. But they did say combined with exercise can lead to better outcomes. But yeah, compression's good. I like just simple elevation and just moving it, just kind of getting a muscle pump is nice. I feel like that's pretty helpful, but I don't know. A lot of times I feel like swelling just naturally will go down if you allow it to. So that's probably the most effective way to attack it, is just not doing too much too soon.
Yeah.
What about
So
you?
depending on what they need. So like a lot of times if they're painful with walking in just their normal shoe, I'll try to give them an ankle brace just to see
Mhm.
how well they can walk at home or on their own without it. If they still are like limping and it's not comfortable with the ankle brace and we ruled out any type of fractures, put them on crutches for a couple days. So weight bearing as tolerated with a brace and crutches. So I had a basketball player probably last winter that she came in right after, like one day after spraining her ankle, and she came in walking, but she had a pretty bad limp and there was no fracture or anything. We just gave her a brace and crutches and she was good to go in like 3 weeks. So like the first 2-3 days, she was just walking with the crutches and the brace and got rid of the crutches, went through our progressions and she was good. But just making sure that you don't send them home with a limp, I think that's important. And then using like a horseshoe. Have you ever seen those? Like those horseshoe that you can put around the lateral malleoli and then use like an ACE wrap to help decrease the
Uh,
swelling.
I don't think I have.
Yeah.
I've seen a brace that does something similar, like the stirrup
Mhm.
brace, but I don't
Yeah.
think I've seen the horseshoe before.
Yeah. It's like a felt or a foam pad. A lot of athletic trainers use it. So they'll just put like a horseshoe around the lateral malleoli and then just use like a ACE or compression wrap and just graded compression. That works pretty well too, just to help improve some mobility and just get that swelling out of the ankle joint or the lateral ankle.
Oh, I just looked it up. Yeah, that would be the difference between your previous work settings and mine, being in the
Yeah.
athletic training room. Yeah, I think that's all really good. I mean, I think it was grade A evidence to use a brace early on or tape,
Mm-hmm.
um, to assist in preventing another one and just maybe assist in, um, possibly with gait and things like that. Yeah, I think the early interventions don't need to be intense or complicated. You just got to move it to a degree. It's just basically a mobilization first movement. It doesn't take a lot of movement, but do what the ankle allows you and what the person's comfortable with. I feel like would be a good start.
Yeah, definitely. Just early weight bearing and mobilization. That's the key early on.
Yeah. Okay. And if we move beyond that acute stage, um, and this may be a good time to talk about bracing or versus tape if you want to, just because I think that's going to be an adjunct with the exercise based treatment. I know you've already talked about mobilizations, so that'll be something that you continue to do to help with range of motion. We'll get into exercise all the way up to return to sport, but as far as bracing versus taping, um, describe what the guideline says, and then give me your thoughts, since you've definitely been in that environment more than I have.
Yeah, so the guidelines definitely prefer bracing. So there's great evidence for prophylactic bracing to help decrease first and secondary lateral ankle sprains. So that comes to like a big topic. Like you'll see a lot of NFL and college football players, they're all wearing the prophylactic knee braces. But I don't know how many athletes are actually using prophylactic ankle braces. I know myself, I hated wearing ankle braces. They were just too bulky and didn't let me move and bend. I preferred ankle taping. But we know the evidence is after however many 30 minutes, you pretty much lose all the stiffness of that tape. If you start sweating and that tape gets wet, loses that stiffness that an ankle brace provides. So I know I played, and a lot of the athletes that I work with prefer the taping, but the bracing is probably more cost effective in the long run, and it's been shown to do a lot better in preventing the ankle sprains.
Yeah, I think the only thing that they noted, which is sort of what you said, is that, um, the evidence leaned towards ankle bracing, but taping can be helpful, and it's sort of comes down to the athlete's preference. So your preference was tape. It sounds like it's better than nothing. So if that can get you through and not limit your performance, I mean, you don't want to have to, it depends what your mindset is, but if you're worried about getting hurt the whole time you're playing a sport, probably, and it's affecting your ability to play at a high level, like probably don't need to play that sport if it's that worrisome. So whatever helps you, but also lets you play at the level you want to is helpful. So you're going with, personally, you would probably choose tape just with your background, but if we're talking about optimal management, you'd go ankle brace.
Yeah. So if, for myself, I chose tape. I don't think I'm going to have to make that decision for myself anymore. But if I'm working with I hope not. If I'm working with an athlete who's had, say, 2 ankle sprains in the past year and they're getting ready for basketball season, I would push the recommendation for ankle brace.
Okay.
Over tape.
What about, like, there's obviously a million different braces. What would you typically, down to like a soft brace or like a neoprene brace, all the way up to rigid braces? What type of brace would you go with?
Just one of those ASO braces. So that the lace up braces with the Velcro straps that get that heel lock figure 8. I've seen some of Steph Curry's braces, and those things look like hair casts. Those things look pretty stiff. So I think that'd be like the last recommendation. But if it works, it works.
I would imagine a soft brace doesn't really, you might as well just tape at that point.
Yeah.
But yeah, okay. So yeah, summarize, based on the evidence, bracing is more effective in both prevention and cost effective. Depends on the athlete's preference, though, for sure. Okay, so let's, I guess, get into treatment, and I'll kind of introduce this, and I guess I'll probably put it up on our website, because I thought it was an interesting thing that we did when I was at Wisconsin, where we broke down, and it's not necessarily just for, it was in our ankle unit, that's why I'm talking about it, but we broke down from the lowest of low levels all the way up to the highest level of how you would progress exercises, starting at just simple like passive range of motion, all the way up to, we called it from death to dunking. So from as low levels you can get all the way up to, something high level. So I'll kind of break that down with me. But if we move past some of the early stuff like ISOs, passive range of motion, active range of motion, at what point are you going to get into more either like resisted, like isotonics and weight bearing treatment?
How soon will we do that?
Yeah, what's going to tell you when it's ready?
So if they're walking with normal gait pattern and they're getting their range of motion back, and there's minimal to no pain with closed kinetic chain dorsiflexion, I'll start loading just general movement patterns: squat, step, lunge, hinge, things like that. Does that answer your question?
Yeah, and then if we go into more ankle specific, I would start, whether it's if just like a heel raise isometric, I wouldn't go single leg first. You'd go double leg, single leg. You could do seated heel raises, then full weight bearing heel raises. If they get comfortable with that, then I would move into possibly like walking on the toes, or eventually like kind of like a farmer's walk on the toes. It's isometric, it's dynamic, with some load through it, and then just going through like a balance, whether it's just single leg balance. You could start, if it's, if it needs, if it's not ready for single leg, you just start double leg, like in a like a kind of a tandem stance versus a like a split stance. You can add, to make it harder pretty easily, before adding some sort of like foam or unstable surface, you could just have them close their eyes. But yeah, just progress along that. And that's probably my favorite part about rehab for an ankle sprain, is the million different ways you can break up, particularly the balance stuff. I feel like that's always something that can be incrementally regressed or progressed based on the patient's tolerance.
Yeah, definitely. What are your thoughts on using the soft surfaces, or the foam or BOSU surfaces for balance, versus balancing on a firm surface? like just level ground, field, or court? Do you have any thoughts on that?
I mean, I start on firm surface. Obviously, you kind of want to replicate the surface they're playing on, but I think my typical progression, if we just say single leg, would be single leg firm surface, eyes open, single leg firm surface, eyes closed, single leg soft surface, foam or Bosu, eyes open, single leg foam or Bosu, eyes closed. You could have them start to do some dynamic movements, or you can have them anywhere in that spectrum. You can have them, throwing a ball back and forth to you or doing whatever you want. But that would probably just generally be my progression. I'm not against the foam stuff. I think it challenges the ankle quite a bit.
Yeah. I'm not against the foam stuff, but I want to see like perfect ankle position on a flat surface. So a lot of times people will start balancing and their whole entire foot collapses and they're just hanging out in that collapsed foot position, no postural control of the ankle. So just like no arch. So a lot of times I call this like pen cap balance. So I'll put like a small pen or a cap underneath their midfoot and just have them be able to maintain their arch in a neutral ankle position when balanced on one leg without their foot collapsing on that pen cap or that pen. Because a lot of times that I see, or I have seen in the past with my athletes or patients, you put them on like a Bosu ball, like the rounded part or a foam surface, and their ankle is just collapsed. They're not working their ankle. They're just kind of using their hips or their trunk to stabilize, and their ankle is just in a bad position. So that's why I prefer that flat surface, because that's going to be more sport specific anyways. They're going to be playing on a court or a field instead of sand or foam.
Yeah, I think, well, I guess because trying to get someone to, if someone's like typically going to collapse in a weight bearing, like a single leg position, are you training them to work on like just feeling what that like maintaining that arch position is like in sitting first? Are you doing some of those like really simple short foot exercises? I mean, I guess that could be included in some lower level activity before they're comfortable weight bearing.
Yeah, definitely. So that short foot and like all the toe yoga stuff, just to help build the foot intrinsics, just get them comfortable and more aware of that. And then being able to stand bilaterally in a good foot position, like those 3 points of contact, like their heel, big toe, flat on the ground, and then fifth met head. So first met head, fifth met head, and heel are making that tripod and making sure that they can feel those 3 points of contact instead of just flattening their arch.
Yeah, I'm sure I showed you the Mobo board, but like that basically forces you to weight bear through your heel, big toe, and fifth met head. It's quite challenging, more challenging than standing on foam, I would think. So it kind of accomplishes both of what you're talking about, and it lights your arch on fire. But I will like just slightly disagree with you on the foam thing. So, it totally makes sense. You want to work on form before it's like controlled versus chaotic environment. But I almost think it's like you're working on two different things. So if you're working on form, you're working on form. But when you put them on some sort of foam or Bosu ball, it's sort of more of a chaotic environment to me. Not in the sense of like putting them on field and having them make decisions, but in like a lower level sense. And obviously when they're playing basketball or football or soccer or volleyball, they're not thinking about what their arch is doing. And I'm sure they're moving in and out of pronation and supination the whole time. So I almost would think of like the foam balance as just putting their ankle in an unsure position and sort of, getting them to maybe build a little confidence. There's no way they're going to maintain an arch, whether it's been, I would imagine, whether it's like trained or not trained, on the involved or the uninvolved side. But I kind of think of it as like loading it in a sort of chaotic sense versus then loading it in a form sense and sport specific. I guess if that makes sense.
Yeah, no, I like it. Like I like those wobble boards. Those wobble boards are awesome. Like
any sort of. Any sort of
And then,
balance service, not
yeah,
whether foam or BOSU,
yeah.
anything like that.
I think the best thing is, have you ever seen the Slack board? Have you seen that at all? It's
The
a
Slack?
firm, yeah, you should look it up. It's a firm surface on a foam pad. So you're getting that foam balance, but you're on a firm surface to help keep your foot and ankle position.
That's kind of the best of both worlds.
Yeah.
Slack bow balance or slack block.
Yeah, something like that.
Yeah, I think that's the slack.
And we can tag that in the show notes if anyone's interested in that. That's becoming a popular thing that I've been seeing some people use on like social media.
Yeah, I think that, and then like I said before, that whether it's a wobble board or that Mobo board, because it's a firm surface, particularly the Mobo board has some like tackiness to it, and it forces you to be in the position that you want them to be in, because you can't shift weight to the other four toes, and it's unstable. So I guess you could just break it down into stable versus unstable, whether it's foam, BOSU, or anything else. And it sounds like, and it makes sense to lean more towards an unstable but firm surface.
Yeah, definitely. So in terms of our treatment, I know we talked a lot about objective criteria and checklists last episode. What are the things that you're working towards early on? I think you asked me the same thing. I didn't answer very well, but like in the early phase, what are you looking for in terms of range of motion and strength or endurance with the ankle specifically? Any tests that you're looking at?
Well, we talked about the dorsiflexion thing. I want to normalize dorsiflexion, and we can kick around this here in a second, but I'll answer the question first. And then as far as endurance, or I'm going to do some sort of balance, just like a static balance test, whether I want to find whatever their baseline is. Some people can't stand on one leg with their eyes open. Some people may need to have their eyes closed, but I'm just trying to figure out the discrepancy side to side. So that would be one test I do. And I would be pretty happy with, like, again, I'm trying to find their limits. So I might go 60 seconds. I may go 30 seconds. It just sort of depends. I'll look at like a heel raise endurance test. So just see how many, first I'm going to look at a double leg heel raise to see if they are able to invert comfortably. And that's probably an exercise I would have been doing. Obviously before you would go into like a single leg endurance test, just to see what they can do up to 25 reps. Those would be three things. And I feel like that checks the boxes of range of motion, balance, and strength. I'm sure there's other things to look at. And obviously like before you would get into hop tests and things like that. Mm-hmm. But real quick, just for the anatomy piece of this, and this may be too much in the weeds and you may be like, why are you even talking about this? But the ankle is going to be in a more stable position in dorsiflexion. The more dorsiflexed it is, the more just biomechanically stable it's going to be. So, and maybe this is obvious, but to me, that's why lacking dorsiflexion can become a problem, because you're not able to, in particular movements, get your ankle towards a more stable position. You need to have control in plantar flexion, but if you don't have the appropriate dorsiflexion, you're just, outside of you having good muscular control, you're not able to utilize the orientation of the joint to get you into or keep you in a stable position, particularly with like cutting and landing and things like that.
No, I definitely agree. And it just gives you that movement variability as well. So it's almost like the plane has more runway to land. So if you don't have that appropriate range of motion, that plane has a short target, small target to land, and it's easy to get off target. When you have more dorsiflexion, more range of motion, and you're able to control it, that plane has more landing room, has more ways to correct and keep in good positions.
And that's a perfect way to educate the patient, that exact analogy that you just used, as to why they can see if you do that weight bearing lunge, they're like, well, that's totally different. So they'll know for sure, but that's a good way to explain it. Anything you would do is, I kind of describe it as like things I would look for before I'd progress, as far as the things I said. Anything in addition to that?
No, I think that's good. In terms of specific targets, I'm looking for at least like 4 inches from the knee to wall with that weight bearing lunge test to measure dorsiflexion. So 4 inches is like the minimum that I want.
You're talking about toes 4 inches from the wall, and they can get their knee to the wall.
Yes.
Okay.
And then
Where's
we
that
already
from?
talked.
Personal experience.
I can't remember what paper that's from.
Okay.
But a lot of times that's from like TPI or FMS. They just use like open fist.
Yeah.
From the wall to their big toe.
Would that change if they what if their uninvolved side can't even do that?
Yeah. So could be anatomy. And then you also we already talked about the asymmetry, like that 2.5 centimeter distance or difference from side to side, or 1 inch difference. So you want to be within that asymmetry, and then that 4 inches usually gives you a good shin angle of like, I can't remember the exact angle, like 38 degrees of measuring from the tibia from the floor with the inclinometer. Yeah.
You can almost see that too in like a squat.
Yeah.
Okay.
And
so
then,
you do what else?
So the dorsiflexion, just like you said, the ankle endurance. So being able to do single leg heel raises, at least 25 with a good tempo. So you can use like a metronome. And then a lot of things that I really haven't tested, I usually test like single leg balance, eyes open, but eyes closed seem to be the best with the CPG. Everything showed like Y balance test, and then single leg balance with the eyes closed were the biggest differentiators between people that had recovered from ankle sprain or people are still dealing with ankle problems.
Yeah, I think if you just think about what we use to balance, I feel like a lot of people are going to rely on their vision, and based on like the deficits that can occur, that can put you more into that could increase your chance of going into that chronic thing. Taking the eyes out of the equation really works proprioception and vestibular system too. But yeah, so I mean that makes sense. But I think that. But if I have someone who can't even stand on one leg, like with their eyes open, then we have things to work on beyond that. But I would like to see them have pretty good control with their eyes closed.
Yeah, definitely. That's something after reading this, I'll definitely start incorporating more of. I'm usually just an eyes open tester, but I'll start testing the eyes closed. And then one thing that I thought was interesting reading this was some different asymmetry criteria for the Y balance test. Usually I check for within like a 4 centimeter difference with the anterior, and then a 6 centimeter difference with the posterior, medial, and lateral. And in one of the studies, they were saying that if you have greater than equal to 2 centimeter difference reaching anterior, and then greater than equal to 3 centimeters with that posterior, medial, lateral reach, that you're at an increased risk for injury. So they're making it a little bit more strict. So that's probably something I'll start incorporating as well.
No, I think it's good. And the star excursion balance test was another one, and they particularly focused on certain directions that were more effective at I guess differentiating between someone who's doing well versus not, and they had focused on the posterior lateral and posterior medial reach directions, which is sort of interesting since the Y balance was kind of more anterior, which makes sense to me. So yeah, no, those are both good. And I think obviously like there's 1,000 different ways to test objectively, whether it's something simple like balance, single leg balance, but then if you get more into like a dynamic motion, like one of these Y balance tests, something like that, you just probably got to pick one. Like you don't have to do all of them, but just something that's quick and reproducible.
Yeah, definitely. So once they hit those landmarks, that's kind of like that early to mid phase. What are you doing next, or what are you working towards after they have single leg balance and enough endurance and strength? How are you increasing that power and that getting into the plyometrics?
If I'm going to put someone into just beginning a plyometric activity, and there may be a better way to do this, but I just kind of see what they can do. It's almost like just a slightly progressed walk. So I'll just have them do like really small single leg bounds to start, just kind of like falling onto the next leg, just to see how that how they tolerate it, and to see what control they have. And I just sort of gradually progress it. I pay attention to what they're comfortable with. And I'll ask them, like, is that kind of scary to do? Do you feel comfortable with that? And, if they say it's like scary and they're afraid of doing it, I'll sort of get an idea of like, is it so much that you don't want to do it, or are you okay trying it? Most of the time they're okay trying it. So I'll just start uh, a little bit of just very light bounds. I may start with very small drop jumps where they just drop and land on two. And then eventually you can progress the bounds to larger distance between. You can go diagonals, you can do sideways. You can do a drop jump onto two by varying the height of the box. You can you can do a drop jump where you land on one leg. You can do box jumps. You can do a box jump to one leg land. So there's a lot of different ways to do it. But I just start doing something super easy and controlled in the sagittal plane and just see how they tolerate it, how well they do, to see if they're ready for it. What about you?
Yeah, I'm kind of the same way. I like what you were talking about earlier, which just like the toe walks and the heel walks, going forward, going backward. You can go side to side, and then adding weight with like a farmer or unilateral carry. I think those are all really good. Just start building confidence and endurance in that plantar flex position, because we know that's more of that open pack position. And then in terms of getting into more plyometrics or jumping, just starting with like double leg hops or double leg jumps in place, almost like a jump rope. So starting with that, getting comfortable with that. If they're good there, start moving forward. So jumping on two legs, like those extensive tempo jumps forward, going backward. Depending on how they're doing, you can start doing that forward back over a line, side to side over a line, more into that frontal plane. And then you can do like transverse plane, jumping in small circles in place, things like that. And then you can do that same thing with single leg. So starting with single leg hopping in place, forward, backward, over a line, laterally, hopping laterally consecutively on single leg. And then you can just be as creative as you want. So we'll get into those certain like single leg hop tests for time. And like we were talking about earlier offline, it's just being creative and being reproducible with your testing there.
Yeah, I think you just have to figure out what makes you and your athlete like confident and comfortable as you progress into any new stage, and you sort of have to figure out what their preference is, but two, what something that you use that helps you become more confident beyond the objective measures. Because even if you do the things that we had talked about earlier with like the heel raises and the balance, and you see they have good control, when you move into a plyometric, it's especially that first one, it's like, I'm just gonna leap off this and see how it feels. So you have to figure out what you can do to build their confidence, but also make you 100% comfortable that they're ready to start to do some impact loading. And for you, a double leg in place is really good. For me, I like more of like the single leg kind of thing. Not to be clear, it is a very, very, it's like you take a high step and you just fall onto that foot. Like it's very light. But that's, just have what you like and what makes you confident. But there's 1,000 different ways to do it. You got to make sure you understand if you're like, what task is going to be more difficult than the previous task. And then if you can figure that out, you probably can incrementalize, break it down into easier or harder tasks.
Yeah. And then as long as it passed the eye test, if it looks good while they're doing it and it's comfortable for them, just keep on going. Just being conscious of the loading and the volume that you're doing. And then one of the questions that I really like to ask athletes is like, how's your ankle feel with that? Like the biggest thing that I get is, oh, it feels like unstable, or it feels like it's going to give way. Then I know, okay, we've reached the threshold. We should probably change it up or back it down one level to make them get a little bit more comfortable and practice at a lower level, and then gradually progress to that level where it felt like unstable, giving way, like it's going to give out.
Yeah, and the other thing is like I said before, is that scary? Like, because that'll give me an idea of, is that, because most likely you're gonna have a better comfortability with what they can do than they will have with what they can do, just because unless you have someone who's really pushing. So get an idea of where their head's at with a particular task. And if it looks good and you're like, oh, he's ready to progress or she's ready to progress, but they're said that was really like scary to do, then maybe you should stick to that for a little while to help them get their confidence.
Yeah, definitely. So once they've gotten through some of the jumping and plyometric progressions, is there anything else that you like to test or look at in terms of getting back to their sport or getting back to practice?
We're assuming that they're comfortable doing lateral movements, relatively intense. Like, are they running at this point?
Yeah.
Like straight line running?
Mm-hmm.
Okay. Well, I guess the better answer to this would be for you to go through that return to sport progression paper that you ran through, if that sounds appropriate at this stage. Because I mean, my simple answer is just going to be like continue to gradually progress. And we've talked about that control to chaos continuum. I think that plays a big role here also. And your progression can go just as similarly as it did when you were introducing every phase of this, from non-weight bearing to weight bearing to balance stuff and beyond, just working double leg to single leg, sagittal to frontal to combined plane, and just get an idea of what they're comfortable with. But do you want to go through that? I think that might be the better way to answer this question.
Yeah, and we've covered a lot of it, but we can just introduce the paper and then go through the framework. So this is a relatively new paper, and it's called The Return to Sport Decisions After an Acute Lateral Ankle Sprain Injury, Introducing the PASS Framework. So the PASS framework was a Delphi study. So they questioned over like 200 sports physical therapists that deal with a lot of ankle sprains, so field or court sport athletes. And the PASS framework stands for pain severity, so pain during sport participation over the last 24 hours. Then A is ankle impairments. So those are things that we've just covered: ankle range of motion, ankle muscle strength, endurance, and power. And then the second A is athlete perception. So you were talking a lot about that: perceived ankle confidence or reassurance, perceived ankle stability, and their psychological readiness. So how do they feel while they're doing progressively harder tasks? And then the last two S's are sensory motor control, so proprioception and dynamic postural control and balance. So that's like our single leg balance with eyes open, eyes closed, our static surge and balance test, or the Y balance test. And then what we'll get into next are the sport and functional performance testing. So hopping and jumping tests, agility tests, sport specific activities. So getting back to team sport drills or individual drills or practice, and then ability to get back to a full training session. So these were 16 criteria that leading physical therapists picked as return to sport criteria. They didn't give specific criteria, but that's pretty much what we've done. We filled in the gaps with what we would like to test with these specific markers. And getting into that sport specific testing, almost like ACL testing, there's a few papers with different hop tests. And the biggest thing that was in the CPG was single leg hop testing with the time domain. So they didn't give specific tests in the paper or the CPGs, but they said that giving a single leg hopping task under a time constraint is going to be one of the best functional tests or functional measures that you can do. So this was a paper in JOSPT from probably within the last 10 years. And it's called The Ability of 4 Single Leg Hopping Tests to Detect Functional Performance Deficits in Individuals with Functional Ankle Instability. And it's going to be hard to explain it, but we'll post the paper to our website and show notes. But it's pretty much just measuring a figure of 8 hop test. So you have 2 cones that are like 5 meters apart, and then you're hopping in a figure 8 on one leg 2 times around. And you're doing 3 trials, and you're just timing the difference, right versus left. And then, like we talked about earlier, a single leg line hop test over 2 lines that are 30 centimeters apart. So hopping side to side on one leg and seeing how many times it takes to do that, or how many reps you can do in 30 seconds. Or you can do it a different way, is how long does it take you to do 10 reps? So different time domains, different reps. And then a 6-meter crossover hop test. So see how long it takes you to hop over a line, crossing over, zigzagging over 6 meters. And then a square hop test where you have a 40 by 40 centimeter square, and then you're hopping in a clockwise or counterclockwise direction. So you hop in, forward, and then out, lateral, back in, hopping forward, hop backwards, and then hop laterally in different directions. So you're pretty much just making a circle around the square. And you're doing that so many reps and seeing how many or how long it takes to get through so many reps of that. So again, there's just 4 different examples there. But as long as you're able to make a test that's repeatable and measurable, then you can pretty much be as creative as you want.
Yeah, one of the papers said that the figure of 8 hop test and the side hop test showed significant differences between limbs in the instability group. And that paper was from 2009. Just looked it up.
Okay.
Yep. So yeah, and then I think it falls into it, depending on their sport, that control chaos continuum. You definitely have to work on reactive balance in a chaotic situation as similarly as you can to replicate the mechanism of injury without them actually repeating the injury. I think doing things with your eyes closed is, to me, is like big, just for the sensory motor deficits that occur after ankle sprain. And then, unless you have any other final thoughts, the last thing would just be like we talked about. There are the clinical practice guideline did show support for ankle bracing and exercise or balance program for prevention of a recurrent sprain. That's probably, and I don't know how long, I mean, you would need that. You might as well just wear the brace, or I guess you could do the tape, but continuing to work on the like a balance program or a proprioceptive program, just to prevent another one, because to get into that chronic ankle instability, you're having recurrent ankle sprains. So a little bit of a maintenance program would probably be helpful.
Yeah, and it depends on the level of the athlete or the person that you're working with. So if it's a high school or college athlete coming back from an ankle sprain, as long as they're in a good training program, that should cover it. So if they're doing single leg exercise like single leg RDLs or different types of bounds or jumps, single leg landing, that'll take precedence over standing on one leg at home balancing. So just depends on if they're in a comprehensive exercise or strength program. A lot of times that will cover it. If not, then we can start supplementary exercises with single leg stuff, single leg balance.
Yeah. No, I think that covers it. Is there anything else that you want to add that we didn't talk about?
I think one thing that I forgot to talk about in the initial evaluation were like special testing. So
yes.
Yeah. So in school, we're all taught like the anterior drawer test. And the new CPGs, they found that that's not as accurate as the reverse anterior drawer test. So that's something that I learned during residency. So I use both of them, but I think I'll probably just stick to the reverse anterior drawer test. Are you familiar with that? Have you used that one before?
I haven't used it before, but I have heard about it before, and I dove into it a little bit once I read that part of the CPG. And I was thinking too, and I'll let you kind of describe what it is, but and maybe you can describe what you're looking for, because we're not necessarily worried about at that point like diagnosing if they had an ankle sprain. Like that's pretty much determined by the mechanism, but I would assume you're looking more for just accessory motion at that point.
Mm-hmm. Yeah. So a normal anterior drawer test is where you stabilize proximally on like tibia, and then you're pulling the calcaneus anteriorly, checking for too much glide or too much motion or excessive motion. The reverse is pretty much exactly the opposite. So the way that I do it is they're laying supine, knees bent, with their heel stabilized on the table and their foot flat. And then I'm stabilizing their talus or their foot, and then I'm gliding posteriorly on the tibia. So that's a relative anterior glide. So I think that's just, for me, learning that in the residency, that's just an easier way to assess it. That way their foot's not hanging off the table and they're not guarding. They're in more of a supported position. And it's just easier to get a feel to how far posteriorly that tibia goes relative to just how far you can get their calcaneus and the talus move anteriorly.
I assume this would only really be used in a direct access situation. Would you think? Because with the, I guess with the excessive, if there is excessive accessory motion, is that something that that's really gonna change your treatment? Unless they're direct access and you're like, you may need to go get this imaged.
As long as they pass the auto ankle rules, it's not going to change my treatment. And even in the CPGs, it was saying that they were measuring it with a specific device. The amount of laxity in the ankle didn't relate to functional outcomes. So if someone's ankle was super lax, even after they were improving, it didn't lead to poor outcomes. So I think it's just good to get that assessment, just like a shoulder. You just assess like their different glides of the shoulder, just to see what that ankle joint is or how that ankle joint is moving acutely.
Yeah, I guess it may give you some indication on like back of your head, they may be a little bit more unstable.
Yeah.
Like as far as passive restraints go. Okay. Yeah, that makes sense. But it's also good to know that reverse ankle joint test is better officially than the anterior one. Okay. Yeah, I think are we good? I think we're good.
Yeah. I don't really have much else to add. I mean, it's definitely, hopefully everyone's going to be seeing more ankle sprains in their clinic with more direct access for PTs. So something good for people to read up on and get comfortable with it.
Yeah, I think it's a pretty fun thing to rehab. From my perspective, obviously not fun to have one. But I think there's a lot you can do with them. And I think you typically see good progress. And there's a nice component of your ability to really teach and reassure the person who naturally is going to be a little bit fearful, particularly with that sense of instability. And ankle sprains can be quite painful. So it can be obviously a little bit concerning psychologically. So there's a lot you can do. I think you always see good progress. I feel like it's pretty rewarding. Yeah. Okay. Well, do you want to close it out?
Yeah, we can close it out. So again, thanks everyone for listening. If you're interested in any of those papers, we'll make sure to post it on our website and in the show notes. And I think Josh is going to put that continuum from death to dunking if he can upload it or find it. So we'll have a good progression from acute to return to sport. So that'll be good for everyone to look at. So appreciate you guys. If you have any questions, reach out to us.
Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.